So over the next 15 minutes, we will explain to you the compelling reasons for establishing a programme to transform outpatients. We'll describe the approach that we've taken, the impact to date, and our ambition to replicate that impact widely. So why focus on outpatients? Well, first of all, we knew that we were not delivering the quality of outpatient experience that our patients deserved. And this was reflected in regular complaints across a wide range of issues and a distinctly and very disappointingly average performance in the National Outpatient Survey. Part of the problem was prolonged waiting and waiting and waiting, spilling over into frustration for all and poor quality outpatient consultations, again fueling our complaints. We followed the journeys of individual patients represented here. Red bars show waiting time, green the productive face-to-face time with a clinician. And as you can see, the balance was completely wrong. The time we spent sitting watching in outpatients gave us some real insight into the patient's experience, into the waste, the duplication, the poor layout, but of course the opportunities. Our baseline data showed that while our overall utilisation of outpatients was a perfectly respectable 85%, that masked the fact that many clinic templates were underutilised and some were repeatedly overbooked. We wanted to smooth this out and ensure that we were using precious central London clinic space and effective consultant time efficiently. Our patient-level costing had shown us that consultant time is a major driver of costs in outpatients. And of course at UCLH, we're also the proud owner of a PFI. We needed to vacate an old building, to demolish it, and to make way for a new facility. But we couldn't find space to relocate the clinics taking place there. So we really do have a burning platform for change. We knew that we had excessive cancellations and rearrangement of appointments. The rework was costing us nearly £500,000 a year in staff time alone, and it featured regularly in our patient complaints and in our governor concerns. And we knew that we were at odds with our commissioner's aspirations to reduce hospital follow-ups and to take patient care closer to home, and as a result, we were incurring financial penalties. And of course, like every NHS organisation, I've no doubt, like all of you, we are facing significant year-on-year savings requirements. In our case, 5% per year, year after year. Our approach to our savings programme is to focus on quality, efficiency and productivity, and we call it QEP for that reason. And that is what we wanted to improve in our outpatient services. UCLH is a multi-site, complex trust, a bit like the trust you've just heard about in Manchester. We cater for both local and distant patients. We have services that range from neurosurgery to maternity to dentistry to geriatrics. We see almost 800,000 outpatients a year in 11 main facilities, and the majority of the patients we see are booked to reattend. Looking at this positively, we therefore had an outstanding opportunity to improve experience for a very large number of patients. But we also wanted to develop an approach that could be generalised and scaled up widely, and potentially to make a difference for millions of patients each year. Releasing time to listen, releasing time to explain, releasing time to jointly agree with our patients their treatment plans.
Thank you very much, Jill. And good afternoon, everybody. So I'm just going to talk you through the Productive Outpatients programme and what we did. And one of the first things I'd just like to draw your attention to is that when we developed this programme, that when we brought in the external expertise to develop the Productive Outpatients with us and pilot it, the pilot alone over 2 large clinic groups cost us £35,000. Now, to take that and to spread that right across our organisation would have cost us 10 million because of the size of the organisation. But more importantly, what we wanted to do was actually have sustainable skills within our organisation so that it could be replicated and spread and adopted. And also, if I draw you back to the case for change that Jill's alluded to, one of the critical points for us was that our clinicians felt out of control of their clinics. Our frontline staff felt their clinics were out of control. So it was fundamental that our objectives were about engaging, training and empowering frontline staff with the skills so that they could do this. So in essence, our objectives became building local capability so they could redesign the services themselves, actually going through the redesign process. But what we also recognised, there was no national toolkit that we could take. So what we wanted to do was develop the Productive Outpatient Toolkit and the methodology, and that's what we did. What we've also done since then is also take the methodology, started it with Productive Outpatients, and taking it into diagnostics and ambulatory care, and you'll hear a little bit more about that in a second. But in terms of our methodology, we developed a 24-week rapid improvement programme. What we did was we took all of the best of the lean tools and the methodology and the approaches, and we compiled it into a structured programme over the 24 weeks. The first phase, 4 weeks, start-up preparation. This was about bringing the teams together. The teams came together, they agreed what their drivers were, what the scope of their project was going to be, and who they needed to engage with. The second phase was knowing where you are. Critical phase built around a redesign event where the whole team would come together, more often than not for the first time ever. And they would agree a vision of what they wanted their service to look like for their patients. And they did that, and then they followed that with a gap analysis to say, if this is where we are and what our data and our patients tell us, this is our vision, what are the things that we need to do to change? They then identified a range of changes that they would move into the improvement phase and start to do. 5S, well-organised working environment, was one of those critical components. I could guarantee any of you that if you were to do this in your organisation, these themes would emerge. But one of the also critical ones was scheduling, matching capacity with your demand on the day. Not 18-week list management. This is about before, but also translating it to what happens on the day. So teams would identify these areas. They'd be given 3 months to make their improvements that would have the biggest impact. And then they would move into the measure, monitor and sustain phase. And critically, all of this was supported with expert training. We provide an expert training programme and coaching support for all of the teams that went through this. And it was at this point that the National Institute of Innovation and Improvement came to us and said, we really like what you're doing. Can we help you build capability in your organisation? So we developed a collaborative partnership with them to help us to build the capability to deliver this. But then what we also did is we leaned our own programme. Because whilst we had what we call the full fat programme, we had a 24-week programme that focused on all parts of the outpatient pathway and took teams through the 24-week programme with all the education. What we then did was developed a fast-track programme, 6 to 8 week programme focusing on one area where we as a team would provide them with some data and some facilitation, and they would go away and focus on one area. But we also developed the JDI, the Just Do It approach. This is where, as a team, we would provide them with some data and we would challenge with the managers and the clinicians what was actually going on. One example was we had clinics that were less than 40% utilised. And we shared this with the clinicians and we said, just do it, merge, close or increase your activity, but something has to be done, and that wasn't transformation. But what I want to do, as our colleague did earlier, is I just want to introduce you to 2 members of our staff through video. James Frost, who is our General Manager of Queen Square Outpatients, who will tell you what his experience was of going through the 24-week programme, and he is now one of our coaches. And then you'll hear from Gavin Johnson, a consultant gastroenterologist who went through the fast track programme. So I'm just going to let them speak for themselves.
Particular area that's been extremely successful at the National has been the MS relapse clinic. So we spent some time looking at what actually happens when you follow a patient round, and we managed to reduce the pathway from 113 minutes to 57 minutes. That means that we can see more patients, it means patients have a better experience. It means that some of those supporting things like the admin staff or the portering staff are there waiting because they know that patient's going to be ready, rather than the patient come out of the room having seen the doctor, then someone calls the porter. All these sort of delays were unnecessary. And it wasn't until we actually took a step back that we realised that we could do things better.
So as part of our QEP programme within the division, we were asked to take part with productive outpatients to have a look at our particular outpatients, and we've been talking about a telephone clinic for some time, but this whole infrastructure, if you like, and the opportunity to have some administrative support through this really got us to initially do an audit of feasibility, which was just a mini audit, and then carry that through for a 6-month pilot, upon which we then got lots of patient feedback. Well, there was a particular pressure on our service, so we were running lots of clinics on a Wednesday afternoon. Patients were waiting an inordinate amount of time, and very often, given the nature of our practice, they were travelling huge amounts of distances from the tip of Cornwall, South Wales and so on, to wait around for 2 hours. They're missing trains home, and basically our outpatient service was in slight chaos. Well, there have been a number of benefits across the board, some of which we weren't expecting. So I guess obviously enough there are benefits to patients, the really incredible feedback we've gotten from them. We've driven down their travel costs, we've made life much more efficient for them. They have found it really very popular, as one would hope and expect. What we weren't expecting so much is the sort of staff benefits. So we now have flexibility in our outpatients, so rather than cancel a clinic commitment if I'm on leave, it can be done a different time of that week, which is really, really important for waiting lists. And that's not the flexibility we have in moving outpatient face-to-face clinics around, just because of access to the outpatient facilities.
We commenced our programme back in 2011, as Janine said, designing our own product to apply to our clinical services. And here are some of the examples of the benefits we've realised so far. To date, we've demonstrated better patient experience, we've reduced waiting, we've improved access for referrers, we've streamlined processes and released staff time, we've freed up clinic capacity, and we've cut the costs of duplicated work. This is what happened in Dr. Johnson's clinic that you just heard about in the video. 58% of follow-up appointments were considered clinically appropriate for a telephone consultation, and nearly all the patients who were offered this option took it up. Patients were delighted with the alternative approach. More were discharged, and unnecessary follow-up attendances were avoided. In our outpatient services as a whole in the Trust, comparing the year before we started with the first year of the programme, we have seen an increase in discharge rates, and we have released capacity to see our new referrals more quickly, not only to meet the 18-week targets, but also to provide early reassurance and diagnosis and care for patients. We're now on our 7th wave of the programme, and so far we've taken around 12% of our clinic lists through it. Staff are very positive. They're enthusiastic to spread the benefits. And after all, who would want a full and angry waiting room? Who would want the first couple of minutes of every consultation to be spent saying, "I'm terribly sorry we've kept you waiting"? And who would want miles of futile travel around the department every day? We believe that our success to date has stemmed from visible executive support, that's me, Committed managerial and absolutely crucially committed clinical leadership, like Dr. Johnson. We believe that excellent communication has been really important. We have a website with our case studies that anybody can look at. I talk to anybody who will listen about this. And these videos are going to be part of a roadshow that we're going to be taking around all of our consultant meetings. And we've had great engagement of stakeholders, including patients and our Foundation Trust patient governors. Adequate time to make the change has been important. But as you'll see, as the programme has evolved, we now have the 3 options, because we know that time is a very precious resource. And we think this is all about local empowerment, and all underpinned by good information. So, where next? Well, we intend this new productive product to be integral to transformation and continuous, ongoing, sustained improvement in our outpatients in every corner of our trust. With a happy and deliberate byproduct of introducing lean capability into every clinical team. Every specialty in our trust runs outpatient clinics, so this is a fantastic way of reaching them all with lean thinking. As Janine mentioned, we've already launched productive diagnostics and ambulatory care as an offshoot, based on the same principles and some of the same packages. And we're now sharing our programme and providing support to some other trusts. So thank you very much for listening. We're happy to take questions if time permits.